All right, we're back to our Thursday series. We've got 4 studies on the docket today. Little change in venue. Hopefully the blur background doesn't change too much here. First one, associations between meniscal lesion parameters in knee joint structures and symptoms in patients with symptomatic knee osteoarthritis. This one basically took a look at if you had a meniscus lesion, what did that mean for your risk factors as well as potential symptomatology with knee osteoarthritis. So what they did is they took 102 subjects with symptomatic knee osteoarthritis. They did a bunch of imaging to them. They took a look at different parameters like um, how far the distance was from medial to lateral on the meniscus lesion, so how large it was on different parts of it, etc. And what they basically use in this paragraph is to say that, jump to conclusion, these measured parameters were associated with changes in knee structure and increases in knee symptoms, suggesting that meniscal lesions may contribute to symptoms and structural abnormalities in the knee and an increased risk of knee osteoarthritis. Basically, it's kind of like if you had surgery in any part of your body. One of the things that they talk about with surgery is that it is a risk factor associated with degenerative changes in your future. Now, this study is talking about symptomatic knee osteoarthritis. I wouldn't be surprised if, regardless of the fact if it's symptomatic or not, if you have a meniscus lesion, that's probably going to even slightly change your knee kinematics or arthrokinematics, joint movement, and how your body organizes movement. And that will potentially lead to physical changes that we can measure. Other things that can happen is the natural inflammatory process of the body going through this injury audit is going to preclude it to starting the degenerative process, and you're going to have osteoarthritis either sooner or more advanced compared to somebody with your age and other risk factors. The whole point is going to come down to how symptomatic is it and what can be done at the time, and how healthy are you when it happens, and or how willing are you to start doing something about it. So this is one of those where I've treated several non-traumatic meniscus injuries, meniscus lesions. They aren't really a great candidate for surgery unless they have part of the actual structure itself occupying the space within the knee joint. So most of the meniscus lesions that you're going to come across are non-surgical cases. So this is one of those things where we can have this discussion with patients where, hey, you have this, like some of the patients who have surgery, we may notice knee osteoarthritis in your future, and it's in our best benefit, especially if it's with a younger patient, we should probably do something to stay as active as physically possible, because this is a risk factor for developing knee osteoarthritis in the future. It also should get us used to talking about knee osteoarthritis not as something that is completely avoidable or a death knell and a death sentence, but just something that we should let people know should they get an arbitrary image and a doctor or somebody comes back and says, hey, did you know you have knee osteoarthritis? And we don't want to start this whole nocivic or painful cascade and make somebody catch a new diagnosis out of left field. So this is just something we get to talk about with our patients now, and maybe another catalyst for us taking advantage of our health in our more youthful years to make sure that we are more capable in our older years. Now, the next 2 studies essentially go hand in hand for what I want to say about them. And if we actually look at this closely, they kind of say the same thing, even though they're technically different substrates. So first up is the epidural steroid injection for cervical and lumbar radicular pain, spinal stenosis. It's a systematic review. The next study after that is the effectiveness of platelet-rich plasma, PRP, injections in treating with rotator cuff tendinopathy, a systematic review. So I'm going to tease it a little bit. They essentially have the same finding, but let's walk through the first one. So radicular pain and spinal stenosis. First, radicular pain. That is pain that radiates down typically a nervous pathway or a nerve track. And the classic radicular process is going to be a disc herniation in the low back, makes the low back spinal cord and its subsequent nerves angry. So you have this disc herniation, and now you have this pain zinging down one or both of your legs. Like I feel it from my back down to my glute, through my leg, the backside of my leg, past my knee, past my calf, all the way into my heel. That is a classic radiculopathy. So that's what it means when it talks about radicular pain. They wanted to see if these steroid injections would help that type of pain. And then spinal stenosis, this one is, I believe, just spinal canal stenosis. Stenosis is just a narrowing of an opening or a pathway. So when it comes to spinal canal stenosis, where that actual cord sits, the pathway isn't as large as the body would like it to be, either because the bone is starting to encroach towards the cord, making a smaller hole, or we have different infiltration and or swelling of the actual cord structures, which would make the opening smaller by default. You also get potential stenoses in what are called foraminal joints. So as the nerves kind of pop off the cord, they go through two holes on the opposite sides. And that can also have a change in diameter as far as its opening. Again, whether it's physical bony structure, swelling of tissue, etc. Either way, that opening isn't as wide as the body and the nerve would like it, and it develops symptoms. So they wanted to see and take a look at, do epidural steroid injections help these conditions? And through their randomized control trials, what they found essentially for all conditions was that it could reduce short-term pain. And in the radiculopathy, I believe it was short-term pain and disability. But let me take a look here. So for both radiculopathies, it reduced short-term pain and possible decrease in long-term disability. Insufficient evidence to determine whether they could reduce long-term pain in those radiculopathies. In lumbar spinal stenosis, they could reduce short-term and long-term disability. Okay, but not short-term pain. Interesting. And in lumbar stenosis, insufficient evidence to determine whether they could reduce long-term pain. For cervical, it's insufficient to determine if it was effective at all. So they go on to discuss basically that they need to really pick and choose who they use these for, and I kind of agree. A golden rule or golden concept that should really be discussed more often is it's going to be the right treatment for the right patient at the right time for the right reason. If any one of those are not met, if any one of those criteria are not met, the treatment either will not work or the experience will not be great, even if it did work. And this goes for any and all treatments, whether it's pharmacology, whether it's a conservative treatment of some sort like adjustments, or surgery. If it's the right person and it's the right treatment, but it's the wrong time, what do you mean the wrong time? Well, it could be the person's going through financial constraints and the strain of going through that process, that treatment is going to cost them too much. It's going to not be as beneficial or effective if they were in a good financial, emotional headspace, if the time of their life was appropriate to actually have the treatment. And we actually see this a bunch in chronic diseases. Oop, I got to go back to, I got to change my settings for that. In chronic diseases, I mean, there's discussions on when to remove various tumors. Is it right now? What is the risk to benefit ratio? Do we wait for something new to happen with it? And that's on the doctor end, the medical end. Patients will sometimes have a say, like if we have tumors when it comes to the nerves associated with our ears, where they will affect our hearing and they will affect our senses. They're not necessarily, they're technically benign in the fact that they won't really throw the cancer, they won't metastasize elsewhere, very likely, but they will still damage structures associated with them. So they need to be monitored for some time. And there is a discussion with the patient on when you want to go through that surgery. So you kind of get to pick the time somewhat at the surgeon's discretion. And if it's the right time for the patient, then typically we get a better result from it. So is it the right treatment for the right person at the right time? Yes. Is it for the right reason? So this could be, you know, Is it in the patient's best interest, or are we just doing it to get the patient out of our office because we're tired of dealing with this condition? Is it something where we're going to recommend additional treatment right now because we want that financial kickback, etc.? If the patient or anybody connected with that treatment is, finds out about that, leaves a bad taste in everybody's mouth, poisons the water for anybody getting that treatment from that provider, facility, etc. in the future. So we got to have the right diagnosis, the right person with the right treatment for the right reason at the right time. It's also why I see patients on both ends of the spectrum when it comes to these things. I see patients where they will swear by a particular treatment, particularly the next one, the PRP injections. They're like, oh, it was the best thing ever. Every patient should get one, bar none. But I also see patients where it's the exact opposite. That never worked for me. Don't tell anybody ever to get it. So what gives? Well, even if each one of these is valid in its own right, it's only valid for the right person for the right reason at the right time. Same thing with like adjustments. I can repeat this with anything and everything. We see where I'm going with this. What it means is we get to have these discussions with the patients about what the treatment actually means, have a proper informed consent, and we get to try and pick together if this is the right treatment for that person in front of us. So, hey, patient, you are in some pain, but it's not disabling you, and you're able to do what you need to do on a day-to-day basis. Maybe this injection isn't the thing for you because it's extra cost. There's the chance to fail. Like anything else, there is always a chance that it won't work. And can you live with both potential results? If it succeeds, it's only going to reduce the pain, maybe short-term disability, but that's not an issue for you right now. So is it really worth it? And then we have some of the risks associated with it. Even if it's a relatively common procedure, there's always risks. Are they worth it for you? And on the other side, can you deal with this treatment not working even if you pursue it? So you get the injection and now it doesn't work. What do you do? So can you live with both of those potential results? Or since it's not really affecting your life and you can tolerate a moderate level of pain, do we just go through with traditional physiotherapy, physical therapy, chiropractic, whatever it is that is going to work in your favor to get this done in the long term, since this is only a short term thing, right? I mean, I could talk about adjustments with this. Hey, patient, this adjustment I feel in the short term is going to help a lot of the pain to set us up to do some of the exercises that you need to do to stay active, fit, healthy, etc. Here are the benefits I'm proposing. Here's a potential side effect in the area we're discussing. If you have osteoporosis, we're probably not going to do it. If you are concerned about whatever, we're going to have that informed consent talk. Can you live with both results? If it works, we have that window. Are you going to pursue? If it doesn't work and we don't have that window, we're still going to need to do this anyway. Are you mentally prepared for both of those results? And what is the long-term plan? Now, let's take one more example before we go to PRP, because I think if I explain this, the PRP stuff I can breeze right through. All right, let's talk about somebody who, hey, no, doc, I need to go back to work. I am on my feet all day. I'm a line chef. If I don't work, I lose my job, etc. I do need something short term to get me through. Oh, look at that. It's the right person for the right reason, trying to keep them at their job, trying to keep them working. That's going to keep them in the right headspace. And it's a good treatment for this scenario, the short term. So it's for the right person for the right reason. Now, is it the right time? Yeah, because great. We then have them go through it. We have to do that with all potential treatments and with all potential patients, bar none. And I think that's just a standard we need to hold ourselves to, that I hold myself to. So yeah, that's my little spiel on just adding to what I've been saying for the past several weeks on these different injections. So one more. This is on the flip side. Typically, a lot of the people who are, going to get an epidural may or may not consider PRP, but a lot of the people who don't want to consider an epidural are, more likely to consider PRP. So I find it fun that they're going to say essentially the same thing. So this one, 2,500 participants included in these randomized controlled trials. It found that PRP did significantly reduce pain and improve function in the short term compared to placebo and corticosteroids. Why did I emphasize that? Let's look at the next sentence. However, long term benefits beyond 12 months were limited with re-tear rates and functions similar to control groups. So basically, just like epidurals, it did not help in the long term compared to anything else, which means I get to have the same conversation. What are the pros? What are the cons? Are you good with either result? If it succeeds, if it fails, what are the other options? And hey, fine, same patient base. You can deal with the suck in the short term. You don't need to go through with it. You don't need to spend the money, and let's just do the traditional stuff that's shown to have proven benefit. Hey, you need to stay at your job, yada, yada, yada. I'm a solo breadwinner for my family. If I don't get back to work, nobody eats, and I have terrible shoulder pain. Fine. We'll talk about finding a reputable clinic to do this to help with the pain in the short term. Just understand, even if it improves pain and function in the short term, I think they're connected. Improvement of pain will improve the function. It's not that the injection does the function improvement itself. But if we don't do anything else, you are going to have the same re-tear rates, et cetera, and it's not a magic panacea for this shoulder condition. So essentially, in my mind, different substrate, different mechanism, different approach, um, same result, which I find cool because, again, patients may have their preference on what they want to put in their body or the process they want to go about it. Absolutely fine in my opinion. It's just that these PRP injections aren't really typically covered by insurance just because they are regenerative medicine thing, which again, I'm a cash practice. I don't, I'm not going to try and coax anybody to go through insurance routes, but I understand it is a factor that people weigh in the care, and it may be something just to consider when we're talking about this. So PRP is a regenerative medicine thing where they're going to take your blood, spin it down, separate the platelet-rich plasma, combine it into a cocktail, inject it into the area they're going to treat, so that the thought process is you're going to get a bunch of super healing juice, essentially, with different stem cells, different rich nutrients into a starved system that's then going to help kickstart the healing process, and bada bing, bada boom, regenerative medicine, you get healing. So it's really cool to see that, at least in the short term, it's an option for pain. And I believe, in my opinion, that reduction in pain will improve short-term function. But if nothing else is done, same re-tear rates, etc., it doesn't matter. It's not a magic pill. So just like epidural steroid injections. Now, the last one, I can get into a bit of a rant. I'll do my absolute best. I'm not actually disagreeing with this. Like, I just want to add a little bit of clarification and perspective. I feel like I'm on Ratatouille. I'm here to provide perspective, linguini. Yeah, I'm sorry. Basically, what they found is that there is a linear relationship to increased ultra-processed food consumption and all-cause mortality. They took a look at countries where they had relatively low intakes in Colombia and Brazil, intermediate in Chile and Mexico, and high in Australia, Canada, United Kingdom, and unsurprisingly, the US. And the results basically showed that what I just said, linear dose response association between ultra processed food consumption and all cause mortality. And they had, where's the other number here? Oh, here it is. In each of the 8 selected countries, estimations varied from 4% to 14% of premature deaths attributable to ultra processed food intake. So, what do I want to say about this? What's new? What's a surprise? Like, what do you have to talk about this? It's really to not doom and gloom the food itself, and really kind of put my way of thinking about ultra processed foods. We have to kind of understand some of the language in the study. It was a dose dependent response. So the poison is in the dose. Why do these foods do what they do to our body? A lot of the times it is because of the whole nutrient profile balance. And I'll get into that in just a sec. It's also one of those things we can't demonize every processed food. Why? Because under the category of processed foods, there are actually several that have the opposite effect. Quite literally, they will extend your life. Well, that can't be right. What do you mean by that? Well, let's take a look at something like whey protein. It has found to help, especially in those people that don't get adequate protein intake, adding whey protein, balancing out your macronutrients, getting what you need from an amino acid profile, really has a profound impact on your health in a positive way. Whey protein, by definition, is a highly processed food. You have to process the dairy product a lot to extract the whey protein and form its own powder. That's one example. I, through my own online store, Fullscript, it's more of an online dispensary, will sell supplements, herbal supplements, other vitamins and minerals, etc. All of those highly ultra processed in many regards food substances. Some more than others, but that's more of a nuanced debate than anything else. But those things can help our health. They are an ultra processed ingredient, food, pill, etc. So it's not necessarily the processing that is the issue. The issue lies in typically, and as a food group whole in a grocery store, what we consider classically ultra processed foods. It is either what gets added or what gets removed, and our diet percentage of how much of these foods we eat, that is the issue. Put another way, if I have a mainly healthy diet, I'm eating like anywhere from 80-ish% plus of quality healthy foods, I can probably get away with eating 10 to 20% of my calories in these various foods without any detrimental health effects that we know about so far. Now, some people, their genetics may make them more resilient to that way of eating. Like they may be more able to eat like a campground raccoon and get away with it for a while. And others may be more sensitive to it, where maybe it's not an 80-20 split. Maybe it has to be a 90-10 or 95-5. So there is individuality to this, but as a whole, it comes down to how much of this food are you eating and the devil's in the details as far as why this is health detrimental. Let's take two examples. Let's take a bag of potato chips. A couple of things wrong with that as far as from a health nutrient balancing profile. We get too focused on what oil was it cooked in, blah, 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 blah. Potentially a factor, but not the main detail on what is the issue with eating a ton of potato chips. They're going to have a ton of calories, high in all the poor kinds of fats that we don't need an excess of in our American diet, and a boatload of salt typically to add flavor to this item. So you're getting a lot of calories with very little additional nutrients to them. So very little fiber, very little protein, a bunch of fats, some carbs, and a boatload of sodium. We still have a bunch of calories to eat in the rest of our day to try and make up our energy requirements as well as our macro requirements. And now we've put a whole bunch towards these potato chips. We're not stacking the deck in our favor to balance this equation out in a healthy way. Well, fine, I'm going to eat a bunch of deli meat. That's got a bunch of protein in it. And you know what? You're right. It may be a better option when it comes to the macronutrient protein, and you're always going to want me to say eat more protein, and I'm not going to completely demonize deli meat. However, if you have 3 deli meat sandwiches a day, day on end, that is a lot of nitrates, which can potentially be carcinogenic, and that is still a lot of sodium, which has a lot of issues in our cardiovascular health. So I don't want us just to think ultra processed. So the takeaways. I don't want us to just think that ultra processed foods are only your potato chips, your candies, etc. I want us to understand that ultra processed foods can include whey protein, it can include healthy substances as well. So do not just talk about this without understanding that. And that when a lot of these studies, when they talk about those things, it does typically mean what we traditionally refer to. But I don't want us to demonize the word ultra processed food. I want us to understand that it is those types of foods, what they either add in, so excess salt, fat, sugars, or what they take away in the form of other healthy nutrients that makes them disadvantageous or not advantageous to our diets as a whole. Okay. So, ultra processed foods, when consumed in high amounts, are bad. Ultra processed foods, as a blanket, I think our bodies are more than resilient enough to have these as a fractional part of our diet without much health concern. And before somebody gets in the comments, yes, I understand there's individual nuance with that, but that's not here now. And again, the main takeaway is going to be the doses and the poison. Okay. Just tying that last little point. That's the other one that I want to make here. The doses and the poison. So you're telling me I can't eat this? Nope, not at all. I am telling you that it's probably just the amount. So if you have, you know, even a healthier option in the form of deli meat, there's still a dose consideration I want us to have. Okay. But I love all of these things. Yeah, but you're eating like 50 plus to 80 plus percent of your calories in nothing but these foods. That's the issue. If we focus on whole foods, basically what everybody can search social media and find these key buzzword terms: whole foods, healthy diets, etc. Most of us generally know the direction of foods that we need to eat to be healthy. If we just preface eat more of those, we don't have to completely shun these ultra processed foods. We just have to consider them and understand what they are. And that is a lot of the times a very tasty, but not very comparatively nutritious, like calorie to nutrition ratio. Therefore, if if I'm working out and I'm doing like a run, fine, give me some quick carbs. I'm not going to complain one iota. But if I'm doing what I'm doing right here, sitting down for 8, 9, 10 hours doing desk work, paperwork, not using that energy, maybe not something my body wants or needs a bunch of quick bursts of energy or the excess sodium or the excess fats, etc. But I'm starting to rant. In summary, ultra processed food, it is not necessarily the processing component that is the main issue, since we find healthy, good ultra processed foods such as whey protein, vitamins, minerals, etc. So do not just demonize something because of that label. Understand why these foods are detrimental to our health. It's typically in the dose itself. Our diets are too heavily invested into these types of foods because admittedly they are cheap, they are tasty, they are calorie dense. We do meet a lot of energy needs, but at the cost of nutrient value. We're not getting the nutrients we need in our body. We're replacing them with other things. These typically have a lot of preservatives in the forms of sodium, which is going to have cardiovascular risks. It has too much bad fats where we're going to have adverse metabolic issues with. And it really comes down to a dosage issue. So it's not that those, if I eat a candy bar, I'm automatically doom, gloom, you're going to have heart disease now. No, it is a dose issue. Okay. So don't demonize the process. Understand why these mechanistically are an issue when we eat them in the amounts we eat them in. And it is not going to mean that if we actually adjust and eat these at an appropriate ratio level, that they in themselves are going to be disease causing. It is the dose. One candy bar versus 10 is a big difference. Okay. A big, big difference. Yeah, now I'm just starting to get off topic. hopefully that makes sense. If there's anything that's still clear as mud, reach out to me, send me a comment, and I look forward to next week.